So because I really like Dr. Zakaria, can we have the slides, please? Up with the slides, please. Yeah. So we're talking mitral valve. So this is Alfieri, and the handsome man beside him is Dr. Zakaria, smiling with all his teeth. So this is where it all started, the thoughts of edge-to-edge repair. So we're going to jump and make it more interactive. 75 years old gentleman, 20% whose ejection fraction was before ischemic cardiomyopathy, atrial fibrillation, and we know from these things usually percutaneous option might be lesser risk in these kind of cases. Here are the parameters. We're going to go more in depth when it comes to the imaging, but we have a 20% RV is moderately reduced in the function, which is posing a very risky situation. We have a PA pressure of 45. We have a severe mitral regurgitation and a symptomatic heart failure presentation. And these are the images. And now I'm going to give the mic now to Dr. Zakaria. Reem, can we give Dr. Zakaria a mask? Can we have his procedural slides, please?
So from the 2D image, although I have only the 2D with color, I don't have the 2D, but it's clearly that the jet is coming more of a medial part. In the two-chamber, we are seeing from left to, or sorry, from right to the left, the segment will be P1, A2, P3. And the jet is coming mainly between A2 and B3, which is a bit unusual for the functional MR. With the ejection fraction of 20, I was expecting that this is a purely functional, where it will be a central between A2 and B2. But in here, it's the location is a bit different. So that's the analysis or the comment about the jet location. The severity, you can see it's a wide jet, so and the vena contracta is wide. It goes with moderate to severe MR. So yeah.
Can we have the smart screen on the screen?
Sorry. Yeah. So that's what I was. One more. Is this a first? Yeah, okay. So, yeah. So, that's the two-chamber. That's the appendage, your landmark.
Smart
so
screen,
that's
please.
P1, A2, and B3. And the jet is coming from here, from this location, which tells you that it doesn't go with the functional, the usual functional secondary MR. Usually we are expecting, if it is the purely functional, the jet to come from here, but as I said, this is a little bit different.
Okay.
So that's my comment in this, and we will see more in the 3D, and we'll talk about.
So, of course, one of the things that you have to delineate is the LVOT, and make sure. So this is a 3D images.
If you go back, Dr. Sondos, we will talk about the length of the posterior leaflet measurement. That's from the LVOT view. We are looking at the measurement of the leaflet from the tip of the leaflet, avoiding to take the measurement of the avoiding to take the cord till the annulus or the mobile part. We are taking the mobile part of the posterior leaflet, avoiding sometime there is part which is calcified, immobile. We have to avoid to take that part in the measurement, because that will decide which device you will use during the procedure.
So this is the 3D. Any comment about, we're talking about the unusual place of the jet, which is a bit here. Any thoughts about these indentations or clefts?
So in the 3D, you can see there are, in the posterior leaflet, there are 3 deep indentation. One is starting from the left, one between B1 and B2, no, the other, no, the other in the left.
B1, oh, sorry.
Yes, this is the one. And then you see that there is also another indentation between, in the medial part of P1, sorry, B2, and there is maybe another cleft here in the commissure. But if you see that the color is coming from this deep indentation between B2 and B3. Now, usually we use cleft as a terminology, but this is a bit of overusing of this terminology. That's a deep indentation. Sorry, it seems that we have difficulties in the smart screen. Usually, the anterior leaflet, I mean, it is like this. The anterior leaflet is, the coaptation surface area of the anterior leaflet is larger than the coaptation surface of the posterior leaflet. So the posterior leaflet, actually, it is hugging the anterior leaflet. And because of that, there should be some indentation and fold. Actually, it's a fold in the posterior leaflet. Now, this sometimes makes a problem and it create, I mean, it originates the, the MR might originate from there. It is different from the cleft, because the cleft usually it's a loss of, there is a separation, complete separation of the leaflet. And how we do differentiate this between the deep indentation and the true cleft by looking at the extent of the extension of this deep cleft. If it is reaching to the annulus, this is most likely to be a true cleft. If it is not, that's a deep indentation. Also, sometime in the 3D, like in this patient, I hope it will work, the 3D in here. Can you? Oh, okay. So in the okay. So can you put the 3D image? In the 3D, you will see some sort of a thin tissue that it goes with. You can see here there is a thin tissue, and it goes with a deep indentation rather than a true cleft. Now, why we are concerned about this cleft? Because during the procedure, if you go and you take this, if you put your clip in the deep indentation, actually you are making them worse, and you are opening the cleft more, so it's better to avoid that place.
In interest of time, Zakaria, I'm going to cross the transeptal because we had a talk about it yesterday. I will go for this image. So we're aiming now for the trajectory and the perpendicularity. If you can look at the screen behind you. What are your thoughts about the trajectory?
So when you are in the left atrium, we have to optimize our device into 3 steps. First is the position, the static position of the device, and then the trajectory. When we talk about the static position, we want to know where is it? Is it central, medial, or lateral? The trajectory is how it moves when we dive into the LV, whether it dives. We should always aim to the apex, to the LV apex. However, sometimes we intentionally go a little bit medial, like here, or a little bit lateral. But don't go this way or that way, because you are going into the problem, into the cord, and that will create a problem.
What about the perpendicularity?
The third is the perpendicularity, so it depends on the location of the jet and your strategy, which one where you will go. So if you are aiming A2, B2, it's usually 6 to 12. And however, if you are going 2 more commissure lateral, you should maybe do clockwise. Or if you are going medial, you should go counterclockwise to respect the coaptation line.
So I will just let you rest for a second. So, Dr. Anas, you're doing lots of TEERs. What do you think about this initial? Are we a aorta hugger or our direction is good? What are you going to tell your interventionist?
Yeah, so you're a little bit, aorta hugging and posteriorly directed. I would basically say that, you're a little bit aorta hugging. Maybe you can use some plus or something like that just to kind of adjust that angle. I like the bicommissural view. I think you're well aligned, but you're just a little bit aorta hugging, a little bit posteriorly directed.
So I think here we have corrected our aorta hugger, and you can see the drop of the leaflet. Are you happy, Dr. Jamila, with grasping, or you want to optimize the grasp?
So looking at the first view, because this is a long axis view, but there are two different locations of the clip. So the one on the right side, the clip, as you can see, is more closer to the leaflet, so you can see the drop down of the grasps on the leaflet itself. And you see that motion of the anterior leaflet. So that's motion of the anterior leaflet that's usually worrisome. The echocardiographer and guide the interventions, that's the grasping in that area is a little bit overstretch, and a little bit of modification and optimization would be better. So you're really worried that this will be detached while the
You want to
grasp is...
optimize.
Exactly.
Okay, so we have some, as we agree as a plan, we can see still some jet coming from it. We aim for re-optimize, as you have suggested. Now we are amending the position. There are some jets still, but at least we have abolished whatever jet from there going on. So, Dr. Zakaria, what are your thoughts now about the three images? So, first, second, and now a second device, maybe.
So you can see that we went medial, but there is the jet which is coming medial to the device, which might be coming from one of those two clefts.
Mm-hmm. So you'll amend and tell them.
Yeah.
So we can see the first device was deployed, and you're coming with the second clip now, amending the position, pushing it. It's a bit more tricky to come in the more medial.
Yeah.
So, Dr. Anas, what you will suggest to take, what kind of toolbox, if you have NT, NTW, XT?
Yeah, I would go with a thin device. So either, depending on the size of the leaflet, either an XT or NT, because we're too commissural, and there's usually more cords at the commissure. So I don't want to create some damage. So I usually just go with a thin device. Usually I have an easier time grasping with a thin device in the commissures. Okay. So depending on the length of the leaflet, if this is a small valve, small leaflet, I will go with an NT. And again, a minimum of 6 millimeters is needed for the NT. For the XT is 9 millimeters of posterior leaflet.
Okay. Dr. Ahmed, so what do you think? Now you're seeing our work. Will you tell us things are going in the good direction or bad direction?
Yeah, I was a bit worried about the patient selection to start with, because this is going to be very difficult, and we expect the difficulty here, and we can see it. The problem with the TEER most of the time is when to stop, not when to start.
Yes.
I think when to stop is very important. I think at the end we have to accept a little bit of compromise. I don't know if we are going in the right direction.
So, okay. Yeah. So, Dr. George, this is how we think. Do you think the alignment of our first device and the second device of an A would have helped the strategy with the presence of a cleft, or any thoughts?
Again, I think the previous comment reflects the reality of this, and but I mean, I think that this positioning now, because you're complementing a little bit the first clip, might be beneficial, and I would happy to deploy at this level.
We have some gradient. What is the acceptable gradient intra-procedural, Dr. Zakaria?
Usually I don't like to exceed more than 5. However, in the sub-analysis of the co-opt trial, they are accepting more than that, up to 7 or 8. So, yeah, I know you are, but most of the cases we don't go outside of the cath lab with more than 5. Usually we don't.
Can I direct this question to the interventionist? Because usually when we report a mean gradient, that's okay. What's okay for the interventionist? Echocardiographer doesn't like to go beyond 5.
The okay for us is not a number, it's the patient. So treat the patient, don't treat the number, number one. We have some data that support, but don't go, for example, if you're talking about 65 years old, and for whatever reason you're doing a TEER in this patient, I won't go for more than 5 as the career, because I know the next day is going to be 6 or 7. And the baseline hemodynamics in the floor is a contributing factor because, anesthesia has a role. Second point is the hemodynamic response. So one time I have done a case, no MR basically, but the mean A went significantly high, and I didn't like it. Then we optimized the position, we changed the strategy, and the LA went down with mild MR. So you have to take hemodynamic in consideration also.
Absolutely. Actually, you mentioned major points, Dr. Sondos, but I think within the procedure, in the intro procedure, the hemodynamics of the patient usually is underestimating the gradient. So having reassessment post-operative, that's really the truth gradient that we are looking for.
Yeah. So we can see at the end, yes, the
Yeah, if I may add, just always check in the cath lab if the patient is on inotropes. This is an easy thing to check. If they're tachycardic, the mean gradient is going to go up. You can sometimes ask your anesthesiologist to slow the heart down a bit so they can get a good assessment. The other thing is that usually a higher mean gradient is associated with worse outcomes in primary MR more than functional MR.
Yes.
So maybe you can take, the other thing is that if a patient is not mobile and is always on a wheelchair or something like that, they're probably not going to feel a mean gradient of 8 or 9 or even 10 compared to someone who's more mobile. So tailoring your procedural outcome for the patient is important.
So this is our final results. We can see that there is basically no MR. And this is what the aim of his strategy was, like to have something like an A figure to to abolish or opening the valley between the cliffs or the indentation. And you can see like a very smidge or a small MR. And this is how it looks, even the direction, because this is going to be coming in relevance in shortly. One directed this way and one directed this way. And this is the transthoracic the next day. And that's why you're seeing one going this way and one is going this way. But at the end of the day, you don't have an MR. And again, what is the gradient accepted? You cannot walk away from the case with the above the moderate MR with a gradient of 8 and you say, yeah, it's acceptable. No, that's not acceptable. When the co-op quartile came up the data, they're talking about functional MR, and they were talking about someone with no MR basically at the end of the case. So you should not walk away with moderate MR and say, well, he's okay, he's 80. No, then don't take it because this is not a good thing. So we can see the next day, still we get in a good shape despite the heart rate in the 70s. And with this final 2 slides, how much of this you're depending on, Dr. Zakaria?
The green is the ideal.
Yes.
I wish I have all my cases in the green in the left side of this of the table, but in reality we have a mosaic color, a mix of every of all these 4 colors. So yes, we depend. I like it, but we have to make a clinical decision regarding which patient we should do or not. And if I am a beginner just starting my program, I will stick to the left side of the table rather than going right.
So the Sky book also has been published recently. I mean, it's free to download. Anyone can have it. It gives you exactly where do you go. As Dr. Zakaria mentioned, go with the optimum and the suitable that going for the expand. Unfortunately, most of my cases, as Zakaria is saying, when we are in the expand and the more challenging. And if you want to talk about, the toolbox, we have everyone in the panels, we discussed this, choosing a long arm or a short arm based on your anatomy and your patient. This is based on, of course, first generation mitral clip system, but the shorter the length of the leaflet, the more you're going to go with a short arm. And with that, we finish the second segment of the first session, and we go for the Dr. Bender, please, if you may grace us with your presence.
Excellent case, Dr. Sondos.
Yeah, thank you.
And medial.
So we're going to be moving now to the mitral case. Sorry, pulmonary case.